Okay, good morning, everyone. I'm glad you can join us today, and I hope I'm coming to you very clearly. I'm Dr. Mark Pasayan, an IT specialist from the QualiMed SDR and DMMC, and I will be moderating today's lecture. Um, this lecture series will not be possible, of course, without the people behind the patient safety and quality management of the QualiMed Health Network, headed, of course, by Dr. Gina Nazareth. First, I'd like to acknowledge the presence of our doctors, nurses, and staff of the network. Shout outs to our attendees from the Daniel Mercado Medical Center, the QualiMed Physician Associates, the QualiMed Training and Research Centers, the surgery centers and clinics, QualiMed Hospital Iloilo, QualiMed Hospital San Jose del Monte, and of course, the QualiMed Hospital in Santa Rosa, Laguna. We are also glad to have with us in attendance members of the different component societies of the PMA. Special shout out to the Tanawan Medical Society. Um, and we are very privileged this morning to have with us a very distinguished speaker who is always trending online, especially in a lot of Viber groups and other social media platforms. So we are expecting a big number of participants for this lecture. Hence, we ask for the assistance of Natra Farm to provide us with a bigger platform. Thank you, Mr. Glenn Bayawa, and of course, Ms. King Balagot for helping us. We are also being streamed live in the QualiMed's Facebook page. So let's get the program rolling. May I invite everyone for a few minutes of silence for, as we all say, a short prayer of thanks. Glenn?
Let us put ourselves in God's holy presence. Dear Lord, it is by your unending grace that we are gathered here today. We thank you for this day and for all the blessings that you have bestowed upon us. For knowledge, so we are ready for bigger things. For wisdom, so we can decide for the greater good. For strength, so we can stand up against every challenge of our everyday. For integrity, to do what is just, so we can be proud of what we do. For compassion, so we can better serve the weak and the sick. For love, so our heart is never lacking despite trying times. And for the gift of life, so we are able to do all this in the glory of your name. Lord, please bless us with your peace and love so we can continue our days basking in the light and warmth of your guidance. All this we pray in your sweet name. Amen.
Thank you, everyone. Now, may I now call on our CEO and the president of the QualiMed Health Network, Dr. Edwin Mercado, for a few words. Sir, over to you.
Yes, good morning, everybody. Special shout out again to our speaker today, Dr. Edsel Salvana. I don't think I need to introduce him, or I guess Mark will introduce Dr. Salvana later. For me, parang si Dr. Salvana is our equivalent to Fauci, somebody credible enough to calm down some frayed nerves and also to provide some semblance of order in the midst of chaos. Also, special shout out to Natra Farm for sponsoring this event. We know that our current capacity is limited, so we asked Natra Farm if we can be if we can use their platform, which can accommodate 1,000 simultaneous Zoom subscribers. But also to the organizer, led by Dr. Gina Nazareth, our consultant VP for our patient safety and quality methods office here in QualiMed. And of course, Dr. Mark Pasayan, our soaking moderator, if it deals or it relates to infection. But today, I'm also looking forward to the discussion of Dr. Edsel. Very important kasi is when will we achieve, or is it really an achievement of herd immunity that the pandemic is declared over? When I did some researches, actually during the Spanish flu, the vaccine was actually discovered much later, 20 to 24 years after the peak of the pandemic. But there came a point na parang there's already a pandemic fatigue, that people already lived with the pandemic and just practiced whatever it is at that time was considered public health. But public health measures. But also moving forward, there are a lot of speculations that things will not get back to the usual thing. Even the way we do work, will it now become routine that work from home is going to be part of our day to day? Even shopping, will it shift now to all online shopping? So bili na tayo ng stocks ng mga online portal, because I think it's not going to go back down to the usual face to face. Even travel and the supply chain, which we realize, especially big countries like the States, when the pandemic hit them, they offshored most of their production elsewhere. So they had a problem on their supply chain. So would that mean all countries now have to keep certain segment of their supply chain onshore? So those are things that I hope Dr. Edsel can put some light in. And I'm hoping that there will be a very interactive discussion moving forward. So thank you very much, and looking forward to a very interesting discussion ahead. Thank you, Mark.
Thank you, sir. Thank you for joining us this morning. Um, Before I begin the lecture, or before we begin the lecture of Dr. Salvana, let me tell you a few house rules. Please always put your microphones in mute, especially if you're using multiple devices, so that we will avoid any audio feedback. Also, we will allot some time for a Q&A after the lecture. If you have any questions, you may ask them later, or you may just key in your questions in the Q&A box, which is located at the bottom panel of your Zoom screen, and I'll read it out later. Okay, so our speaker is a good mentor of mine, someone I look up to, not just in the field of ID, but also in the field of HIV medicine and emerging and re-emerging infectious diseases. He is, of course, no other than Dr. Edsel Maurice Salvana. He is a director and associate professor at the National Institute of Molecular Biology and Biotechnology at the National Institute of Health of UP Manila. He is a clinical associate professor of medicine at the ID section of the Department of Medicine of the UPPGH, an adjunct professor for global health at the Division of General Internal Medicine at the Department of Medicine of the University of Pittsburgh, and an attending physician at the Medical Center Manila and Manila Doctors Hospital. He's a member of the UP College of Medicine Class 2001, and currently a member of the Technical Advisory Group of the Department of Health Interagency Task Force for the Management of Emerging Infectious Diseases. Friends and colleagues, let us all welcome Dr. Edsel Salvana. Good morning, sir, and welcome to QualiMed. Sir, you're on mute.
Oh yeah, that hasn't happened in a while. So good morning, Mark. Thanks for the kind
morning.
introduction. Good morning to Dr. Edwin and Dr. Regina. It's great to be here. I think that more and more we really need good sources of information, because there's really a lot of noise that's going on. So let me just share my screen. All right. Can you see the screen, Mark? Is it clear?
Yes, we can see it, Edsel.
All right. Thank you, sir. All right. So when I was asked to talk, I was asked what would be interesting, and I think everybody wants to see the end of COVID. So that's really what I entitled this talk. What I'll do is maybe I'll touch a little bit on the history of of COVID-19 in our country. Maybe talk a little bit about the variants, some stuff about the vaccine, of course, and even the treatment. So we'll do a little concept map, so to speak, in terms of how we're going to get to the end of COVID and what the tools we already have to get there, and how fast can we get there? So these are just my disclosures and disclaimers. This lecture is my personal opinion. I do have some engagements and consultation fees that I receive from multiple pharma companies. But again, I try not to have any of those affect the content of this talk. These are just my disclosures and disclaimers. So how do we start? In January, if everyone recalls, it's like so long ago already, but it's only been a year. First three Philippine cases were discovered, and these were all Chinese nationals. In February, one of those Chinese nationals was the first death outside China in the world. So we had that dubious distinction. And the other two previous cases recovered, they returned to China. And there were no cases for 2 consecutive 14-day-long incubation periods. In medical field in infectious disease, we know that sets apart a cluster or a wave, so to speak, although 3 cases is a really tiny wave, if ever. And that's really the WHO definition of control. Sabi ba nga ng WHO, hey, Philippines is doing okay. And then, of course, the next day, nagkaroon tayo ng new cases. So in first week of March, we had 2 cases, patient 4 and patient 5, if everyone recalls. Patient 4 was actually from Japan, and so may travel history siya. But patient 5, actually, I think almost all of the ID doctors lost sleep over patient 5 because patient 5 had no travel history, no known exposure to a positive COVID case. And so it may, patient 5 could potentially have been the first documented case of community transmission in the Philippines. And we knew that if there's one, there's probably more. And that was why, as part of the IATF technical advisory group at that time, we were only at 52 cases, but we were aware of what was going on in the rest of the world. We did advise the lockdown. And so these are the reasons for locking down early. We knew that China, Italy, Spain were already being overwhelmed, considering that they locked down at their usual conventional thresholds. Lockdown kasi if you have demonstrated community transmission, and that's usually not just one case, it's multiple cases na hindi mo na matrace yung clusters. Ito, we got worried with patient number 5, and there wasn't really as much yet at that time. But we thought that if we don't act now, we're really going to regret it. And thankfully, that the government did listen to us, and we did lock down. Again, the other background of this was WHO report at that time showed that it was only the lockdown that actually worked to slow down the spread of cases, and there was some reports that the R naught was 3 to 3.5. We obviously do not have the healthcare capacity of China or Italy, and if they were getting overwhelmed, us with maybe 10% healthcare capacity as them, if pupulutin talaga tayo sa kangkungan. So medyo we were already waving our hands at the IATF, and we were saying that every disaster movie begins with someone not listening to the scientist, and kami po yung scientists, makinig po kayo sa amin. And they listened naman for the most part. And the other thing that was really worrying us is that we had a high density of people in NCR, and this can really rip through very fast, and we've seen that happen in India. So just to remind ourselves of the R naught, which is different from the RT. The R naught is actually a characteristic of the virus at baseline, whereas the RT is actually more time-bound in terms of the sum of all the minimum health standards, isolation, quarantine. The effective R naught is the RT, and that changes over time, and that's what we track. And really, you can't completely prevent infection. I mean, it's aspirational. New Zealand was able to do it. Taiwan was able to do it. But for most places, the best thing you can do is to protect your healthcare system. Because what you want to do is try to spread out the infection so that it doesn't overwhelm your healthcare system capacity. Because we know that about 5 to 10% of people who get COVID-19 will need some form of medical care. Particularly those who will develop severe COVID may need ICU care. And if you don't give ICU care to those patients, they're all going to die. We talk about 1%, 2% mortality from COVID. That's overall cases. But if you're talking about mortality in the severe population, if we don't get them health care, all of them are going to die because they need ventilator support, they need oxygen support. So very interesting because this is a fun tracker. You can get this at the Our World in Data in terms of how people were moving around during the pandemic. And you can see that when we did the lockdown, there was a really drastic decrease in mobility all over the place. And then somewhere when the lockdowns were gradually being eased, you can see around June, the numbers were going up. And then I just like to show you that little spike in December. Yan po yung kinatakutan natin na post-holiday rush. And you can see that it was real. Look at how many people were out and about in December. There was a distinct spike. And that's why I'm saying nowadays, we are seeing some increase in cases, but not what we would have anticipated from an increase in mobility like that. So for the most part, we're weathering the holiday surge. But of course, we still have the new variant to deal with, and of course, Vaccination, because it takes 2 to 3 weeks to see the effects of those. For the holiday surge, I think for now we're doing okay. So this is what would have happened if we didn't lock down. Iran didn't lock down. This is the Philippines. You can see how exponential the number of cases increase when you don't do any kind of community quarantine. Very instructive is Mexico because Mexico locked down 10 days after us and they opened at the same time in June. And you look at the effect. The other thing about us is we kept the elderly people, vulnerable population, still locked down, about 65 years old. You see, the Philippines started March 13. We had 52 cases by then. Mexico had 13. March 23, Philippines had 380 cases. Mexico had 316. That's when they locked down. And we both opened up in June. And now look at the number of cases. Mexico has 1.64 million cases and 140,000 deaths. That's at a positivity rate of 30%. So ang laki ng namimiss nila number of cases. In the Philippines, sure, we have 500,000 cases since January 17, and deaths have already passed about 10,000 plus at this point. But it's like nothing like what happened in Mexico. And that's a difference of 10 days. And so the exponential growth, you have a chance to affect it most early on. So you have to be very, very decisive when you lock down. And that's what we did. And just to underline that issue, I mean, this kind of, for months, this actually looks like the Mrna vaccine efficacy. So these are the number of cases in Mexico versus the Philippines. Just to underline the point that we really saved a lot of people by locking down early. So we had GCQ. That's when we started to ease it from ECQ. And you can see that the number of cases really increased. But it really wasn't just the increased mobility because there was an increase in mobility, but it wasn't, people were already wearing masks. So we hadn't done face shields yet at that time. But this is actually coincident with the entry of D614G, which was the original more infectious variant. And this happened sometime in June. So medyo na double whammy tayo. Bukas tayo, sabay pasok ng D614G. So there's no evidence of hidden transmission from the original January cases. I'll show you the lineage genomic data na hindi nahanap. We have not seen lineage A or lineage B, na original lineage in the Philippines until maybe September, which is probably already a reintroduction. Hindi na siya community transmission. And then there were multiple introductions with returning OFWs. It's probably already more than 1 million at this point. Introduction of potentially more infectious variant, hindi na potentially, it's really more infectious, yung B614G in June, plus the opening of the lockdowns. Currently seems to be under control, but now we have the UK variant and other things, so we have to keep an eye on this talaga. So I'll just give you a bird's eye view of the genomic data, which is from RITM. These were the first 17 strains that had whole genome sequencing. So in January 3 Chinese, no evidence of onward transmission. One of them was lineage A, na walang number, which is really the original strain from, not strain, variant from China. And B also, no number. Also, these are the original from China. And then in March, which is at the bottom, sorry, nag-skip kasi B6 yung lineage na nakita sa March, and clearly not related to January cases because this is B.6 now. Yung A and B na walang number, yun yung original variants from China. Yung B6 is associated with outbreaks in India and in Singapore. So nakapasok siya from another source. They say it's similar to the one in Diamond Princess, but of course, Diamond Princess had nothing to do with our outbreak. Why? Because at that time, nung March, nakita natin yung B6, the Diamond Princess Filipinos were all quarantined in Clark. So there's no way they could have they could have spread it to the community at that time. They're just similar variants. And then in June, ito na yung B.1, B.1.1, and now, di ba yung UK variant is B.1.1.7. Basta may B1 ka, lahat yun may B614G mutation, which actually does increase transmissibility. And this was when we saw it in June, nung nag-surge tayo. And nowadays, actually, most of the things that we are sequencing all have the D614G variant because it's more transmissible. It's almost completely replaced the variants in the Philippines from the original variants to everything that has at least D614G. So just a little bit about the D614G variant. There was a mutation from T to G in the 614th codon of the SARS-CoV spike protein. They were able to show in the laboratory that a SARS-CoV-2 with a D614G replacement to G really does confer fitness advantage, higher viral loads, and more stable binding to the ACE receptor. So this is already proven in the laboratory. So let's shift just a little bit about the other variants because that's kind of a hot topic right now. Emerging variants aside from D614G, basically if it's B.1 and beyond, all of them have D614G. Now the UK variant already has the D614G, but aside from that, it also has N501Y, deletion 6970, and over 20 other telltale mutations. And this can increase transmission by up to 70% compared to other variants. And of course, there's other variants emerging, South African, which also has a D614G, Brazil, which is now the P.1 variant, but it did originate from B.1 as well. And then there's the American and Japanese variants. We're still confirming if these are indeed more contagious. We need to do the laboratory work. UK is doing that right now. But, you know, it has happened before and it can happen again. The more infections we have, the more likely that new variant will arise because there's a higher risk of mutation. Mutation is normal to viruses. And so, you know, most of the time it's either a harmless mutation or it's bad pa nga for the virus, but nakaka-jackpot siya from time to time and we get these beneficial mutations to the virus. It makes it more infectious. And so far, wala pa namang more deadly. And the other thing that people are keeping an eye on is any changes in vaccine efficacy. So far, mukhang okay naman yung vaccines natin, although there are some changes to the amount of antibody binding affinity. But for now, it looks like the vaccines will work. If ever, maybe it'll go down by 5 or 10%. But we can always fix the vaccines naman. You know, we can add the variants or we can tweak them. So just to a quick snapshot of what our R naught is right now, it's 0.79 on January 1. Hard to calculate R naughts within the last 2 weeks. The UP Octa, I think they said it was about 1.15, but that's a more recent calculation. And it can change depending on how many more cases come out the next 3 days. But this is what officially DOH is releasing, so it's still less than 1. If you can see that there's like a little dip there in December in terms of the testing output, and that's because less people wanted to get tested and some of the labs were not working out. But the positivity rate has more or less really remained at about 5 to 6%. Overall positivity rate is 8.19%. So more or less stable naman yung number of cases. And again, just to point out that spike in December, and we're not seeing as a what we would have expected in terms of the surge, given that increase in mobility. So the good news is the curve continues to be flat. R naught is less than 1. The post-holiday surge is still possible, but becoming less likely. Of course, the shown is there, plus the new variant. The case fatality in the Philippines is about 2%. This is versus 3% worldwide. Our deaths are relatively low per million population. We have 90 per million population. That's good enough for about 100 deaths in the world. And compare this to the United States, which is 1,231 per million, 1,150 per million in Spain, 1,082 per million in France. These countries per million have lost 10 times the number of people than we have. And that's remarkable considering that these are very advanced countries. The positivity rate is going down, now consistently around 5 to 6%. Of course, this can surge anytime. Malayo po tayo sa herd immunity. So don't get complacent. This can just, this can really come back and bite us. So there's no room for complacency until we get a substantial number of the population vaccinated. So this is where we are. GCQ, you can see gradually going down. Medyo nag-plateau ngayon because of the increased mobility, but not as bad as we expected with the holiday surge, which tells me that people are getting used to doing their minimum health standards. The face shield, I think, helps on top of the masks. So I think the important thing to realize here is that we can keep this at bay while we're waiting for the vaccines to arrive. Just to disaggregate the data, you can see NCR has really controlled its pandemic. Aside from that surge in July to September, it's really remained flat. Rest of Luzon, there are still some indications that this goes up and down. Visayas is kind of flat right now, but Mindanao is also kind of scary. It's starting to peak again. So we have to keep an eye on these countries and have these kind of granular data to guide our policies. And the big picture really is, the U.S. is really in big trouble. They're seeing more than 200,000 cases a day. We've kept our cases at about 1,000 to 2,000 a day. Again, not to rest on that, but actually we want that even lower, maybe lower than 3 figures as much as possible. But again, it takes time to get to that point. And in terms of controlling the pandemic, for now, that's really the priority. So how do we prevent? We know that masks work, decreases risk by about 85%. Physical distancing decreases by about 80%. Eye protection, face shield decreases by 78%. And then I think everyone's seen the Swiss cheese model where you layer different kinds of protection, and this may decrease risk by more than 9%. And this is just kind of a mock-up table that I did. None of this is set in stone, obviously, but these are just point estimates that we have. And the point I want to make here is that, there was a lot of talk about mass testing everybody, getting the whole population. And that was really wasteful because we know that positivity of tests is time-bound when people are incubating and also people who are no longer contagious. And so Adam Kucharski, who's actually a fellow, senior TED fellow with me right now, calculated the effect of what would happen if we just did random mass testing without doing anything else to 5% of the population per week. In the Philippines, that would be 5 million tests per week. Di natin kaya yun. But it would really only just reduce the transmission by 2%. So there are better ways to do this. If you did targeted testing, that's about 60 to 80%. It's symptomatic people, close contacts. And then if you combine this with everything, then you can get to more than 90%. And I think that's why we're weathering the post-holiday surge. But we have limited resources, so we have to invest in those that are most cost-effective. Really, this is just from Adam's paper, that, mass testing, the population will decrease it by 2%. But, all the other measures are much more efficient in getting this, particularly contact tracing, home quarantine, whole house quarantine. Those are important interventions compared to just blindly testing whoever you can get. So workplace safety, and Dr. Mercado had mentioned that this is something that we should continue in the future, even if we've already gotten rid of COVID-19 or at least controlled it. And I think in general, just thinking about, this is not going to be the last infectious disease that we're going to see. And if some things can be done more efficiently, why not keep them? If some people can work from home, if you need to go to the office, maybe instead of every day, maybe once or twice a week, it's a good idea because, maybe less people will get colds, less people will get flu. So workplace safety in terms of hierarchy of controls, if you work from home, you eliminate that. You can do shifts, decrease the number of people at one time, make sure there's good ventilation, acrylic barriers, one-way traffic flow. Of course, symptom screening is important, temperature checks and isolation rooms if somebody is found to be symptomatic. And then, of course, masks, face shields, and physical distance the whole time. So shifting gears to proven treatments, high-flow nasal cannula works, dexamethasone, and a very controversial remdesivir. High-flow nasal cannula has really prevented a lot of our patients from ending up on the ventilator, and it does contribute to faster recovery, and we end up with less complications. The dexamethasone was really the first intervention that was shown to impact mortality, and this decreased deaths by 1/3 in critical cases and decreased deaths by 1/5 in those needing oxygen. It does not have any effect on mild disease, as we know that steroids have their own set of problems. And so we really only give it to people who have severe disease. The remdesivir does decrease the length of hospitalization in those with severe and critical disease. It speeds up recovery, but there's not much effect on deaths. But also because we're getting better at taking care of people, the deaths maybe can be minimized, but 5 days less in the hospital is a big deal. So I think that there is still a good good reason to use it, especially in our patients with severe disease. Under investigation, tocilizumab is plus minus, keeps swinging back and forth. Favipiravir originally had promising data in terms of decreasing the number of hospitalization for moderate risk, but I haven't seen the final peer-reviewed publication. They released their data sometime in September, and so we're still waiting for that. Ivermectin is kind of controversial right now. We're still looking at the phase 3 data for that. Convalescent plasma, especially with the new variants, is going out of favor. Monoclonal antibodies did see some initial approvals, but the enthusiasm, I think, has been dampened because it's really expensive. And of course, everyone's excited about the vaccines. Hydroxychloroquine doesn't work. Remdesivir doesn't work. Interferon doesn't work. And there are lots of other targets that you can see here. Some have not panned out, but they're still looking because, especially for people with severe disease, there will always be a role for an effective treatment for COVID-19 aside from the vaccine. So what about the vaccines, and when the heck are they going to get here? So there's more and more approved vaccines. There's now 10 in the world with EUA or limited use. We have one that has received EUA in the Philippines, and that's Pfizer. I'm only going to talk about 4 vaccines here because that's the data that we have. I haven't seen anything other than just preliminary efficacy data for the others. So Pfizer and Mrna are approved in the US and UK and several other countries. So they're about 95% clinically effective, and both of them do prevent severe disease. Pfizer about 89%. Mrna about 100%. Actually, there were 0 cases of severe in the vaccine arm and 30 cases in the placebo arm, which comes out to 100% point estimate. But of course, we know there's no such thing as 100%. So it's going to be the confidence interval of that is something like 87 to 100%. But the clinical efficacy is reported as 100% for severe disease for Mrna. Astra is approved in UK, India, 5 others, 62% clinical efficacy, but again, 100% severe against severe. The numbers were even lower. It was 0 cases of severe in Astra arm, but about 10 cases in the placebo arm, which gives you something like 57 to 100%. And then Sinovac, which is probably the most controversial, gives you a 50% general efficacy, 78% against moderate disease, meaning needing medical care, and again, 100% severe vaccine efficacy. And the numbers are like 0 in the vaccine arm versus 7 in the placebo arm. And it's kind of remarkable because the Sinovac trial population in Brazil was all healthcare workers, 13,000 healthcare workers. But the other problem was that they didn't test IgM, IgG. And so at least some of those people on placebo probably already had past disease and were protected. And yet this still came out. So I think that even though these numbers are not great, also look at them through the lens. I mean, not great for general efficacy, but great for severe. Look at them through the lens that this was actually a purely healthcare population, and they did not test for severe for previous COVID-19, which we know can be protective from infection. Earliest projected availability is second quarter, end of February is what they said. We may get Pfizer through the COVAX facility, and of course, Sinovac, just a small number, 50,000, and there's still no EUA for Sinovac, so that's not a guarantee either. It might even come in March, so even if it arrives, they probably won't get to use it yet. These are just the types of vaccines. There's protein subunit, recombinant, virus-like particles, inactivated virus, and nucleic acid base. It's always good to have all these kinds so that we can fit them to different populations. For instance, you don't really want to give a live vaccine to people who are immunocompromised, and then there's issues with the mRNA, maybe for the elderly, very elderly population. So, it's good to have that, and it also decreases the risk of emergence of vaccine resistance because you have all these kinds of vaccines that you can use, and the virus can't really concentrate on one resistance mechanism for the vaccines. Out of all these, only Pfizer has EUA in the Philippines right now. And those are the others. There's actually more in the pipeline. Again, there's more than 200 vaccines in the pipeline. So just shifting gears, if you saw my Congress talk, that was in Filipino. I translated this to English and made it a little more detailed, oriented towards healthcare workers. So when we talk about good effects of vaccines, so we're not just talking about clinical efficacy per se, but really whether it prevents severe disease, which can turn a deadly disease like COVID-19 into something like the common cold. Or you can prevent clinical disease, so somebody who is symptomatic will end up mostly asymptomatic. Pero nakakahawa pa rin sila. So that's the problem with just clinical disease. Or the best is something that prevents transmission. So no disease, na nga, tapos hindi ka pa nakakahawa. Even if you're asymptomatic, you don't shed virus. So just to review COVID disease severity, if it's mild, just cough, cold, fever, non-fatal. And then moderate, you have pneumonia, but no need for oxygen, less than 1% mortality. And severe pneumonia with dyspnea and oxygen needed, needs hospital care, 5 to 10% mortality, properly managed. Improperly managed, it's going to be over 50%. So you still have to protect the healthcare system. So why do we want to prevent severe disease? Because it's severe disease that gives rise to potentially fatal outcomes. And for vulnerable populations, which includes us, healthcare workers, because we're so highly exposed and we get high viral loads from our patients who are positive, and also the elderly patients, because they're frail, it can kill as much as 10% of the vulnerable population. So if the elderly population are given this kind of vaccine, you can prevent most deaths. Mortality in frontliners is quite high. This will save almost all frontliners from COVID-19 if we can get a vaccine that prevents severe disease. So examples, COVID-19 is not the only vaccine that may prevent severe disease. If we look at the inactivated polio vaccine, it's actually not transmission blocking, but it does protect against paralysis from polio. Influenza, which is only 30 to 70% effective for preventing clinical disease, actually decreases your risk of ICU admission by 82%. So that's why we keep giving influenza, because we're protecting the vulnerable populations. And for COVID-19, it seems like Astra, Sinovac, and Mrna all prevented 100% of severe disease in the clinical trials. This is not going to be 100% in real practice, but it's going to be fairly high. Maybe 90% or more. Pfizer is about 89%, which is still pretty good kasi may isang nakalusot dun sa na-vaccinate na nagkaroon ng severe. So this is the picture that I like showing people. What do you mean prevent severe disease? So a lion that can kill you We will transform it into a kitten that cannot kill you. It can still get pretty annoying. It can still scratch you, but it's not going to kill you. Um, so now to preventing clinical disease, you won't develop symptoms, or maybe you just have very mild symptoms. Imagine kung COVID was just a cold, no big deal, right? But um, uh, we don't have a vaccine for the common cold na mawawala siya. But it's aspirational, and that's what they're looking at when you're talking about clinical disease efficacy. There's less transmission, yes, definitely, because symptomatics are more contagious. If you're sneezing, you're coughing, even if the viral load is similar in the throat for asymptomatics versus symptomatics. Obviously, if you're not coughing or sneezing, then very little virus is getting out. So, and there's also less need to access the healthcare system. So it really does still have a benefit overall to the healthcare system. So COVID-19 known vaccine efficacy to prevent clinical disease, any symptom, is 95% for Pfizer. Moderna is 94%. For Astra, he did like 4 different trials, it's 62 to 90%. And for Sinovac, for 3 different trials, it's anywhere from 50 to 91%. Differences in efficacy depend on the population selection. For instance, for Sinovac, I told you that 100% of the Brazil trial, 13,000 patients, were all healthcare workers. For Turkey, Sinovac, which had a 91% efficacy, they actually tested for past disease, which they did not in the Brazil trial, and they only vaccinated 15 to 59 years old. So baka mas robust yung immune responses nun, kaya umabot sila sa 91%. Um, uh, Pfizer tried to go for high risk, although I think only about 10 to 20% of them had healthcare workers, but also vulnerable populations. Moderna was about 10%, Astra was about that as well. So the populations are different, and also the ages. Yung Astra kasi, di ba, naging controversial yung half dose versus full dose, and that cohort was actually made up of relatively younger people, and that's why 90% yung vaccine efficacy nila. Pero yung 1:1, which had an older cohort, they only saw 62%. But the severe disease prevention was still good across all those trials. So very important to dig a little bit deeper to understand what these numbers actually mean. So for prevention clinical disease, same lion, you don't kill the lion, but you put it in a cage so that it doesn't really harm you anymore. And then preventing transmission. This is the one that's not guaranteed. I mean, all these vaccines, if they work against clinical disease, will have some effect on transmission. But what we're looking for is herd immunity. And to get to herd immunity, you want a transmission blocking vaccine. Aside from severe and clinical disease, it can prevent transmission. And so it really depends. Because everybody we say that herd immunity from a vaccine, you need 70% of the population. But if the vaccine only prevents 70% of transmission, then you will have to vaccinate 100% of the population. So that's, there's a lot of caveats to that idea in terms of transmission blocking. So herd immunity right now is aspirational. That's not what the current vaccines were studied for. They're studying them now for transmission blocking, but to get the initial approvals, they were looking at clinical efficacy initially. So there's no COVID-19 vaccine proven to completely prevent transmission at this point. There's some tantalizing data from Moderna and from Pfizer that it may block anywhere from one-fourth to two-thirds of asymptomatic infections. And that's the outcome that you want. But the problem is you have to keep swabbing people every week, and that gets really expensive and much harder to follow. So it's really more of a subgroup rather than a big clinical trials that they're doing with the primary endpoints of clinical disease. Transmission blocking is more difficult to prove, needs periodic sampling and closer follow-up. They are going to work on it, but in this emergency, the most important outcome is really preventing severe disease because we want to save the lives of our vulnerable populations. So this is what we want to do with preventing transmission. Kill the lion. I have nothing against lions. I'm just using this as an illustration. So what is urgently needed? A vaccine to prevent death and severe disease among vulnerable groups. And this includes frontliners, elderly, and chronically ill. the most important aspect of the emergency use vaccines is the prevention of severe disease, because it is severe disease that kills people. Vaccines that prevent severe disease will decrease the overall risk of death among the highest risk. So this is the efficacy of the different vaccines. I just threw them onto a table, and you can see severe vaccine efficacy is 100% except for Pfizer, which is 89%. Clinical vaccine efficacy 95, 94, and then you can see the breakdowns there for Sinovac 78% moderate, meaning it decreased the risk of having to go to your doctor. In the trial population, you can see there's 20% high risk, 62 to 91% high risk for Astra, all high risk for Sinovac in the Brazil trial, 10% for the Turkey trial, which I didn't bother putting there because I don't have much data on it, and it was just interim anyway. So if you took 1 million symptomatic infections and looked at what kind of effect the vaccine would have on them, given those numbers from the previous slide, this is what it's going to look like. So for no vaccine, 1 million will develop symptoms, there's no effect. 200,000 will need medical care. 50,000 will need hospitalization, and 5,000 people will die. These are just estimates, These can vary depending on country, age, and whatever. For Pfizer, because of 95% vaccine efficacy, only 50,000 will develop symptoms. Now, because of 89% severe vaccine efficacy, the 50,000 that you see from no vaccine will go down to 5,500. And 10% of that will die will be 550. So, you still decrease the death. For Moderna, because of 94% efficacy, 60,000 lang yung magkakaroon ng symptoms, but there's no clear data on the need for medical attention. But based on the 100% point estimate, none will need hospitalization and no one will die. This is aspirational, ideal setting. Maybe may makakalusot, especially in the real world. But this is what the clinical data is telling us. And that's what we're using to calculate these. You can see the confidence intervals at the bottom if you really want to see how wide those intervals are. For Astra, multiple trials, anywhere from 100 to 380,000 will develop symptoms versus 1 million. Again, no hospitalization, no deaths. And Sinovac, even though half of them will develop maybe a cold, only 44,000 will need medical care. That's basically 78% of the 200,000 will need medical care, will not need medical care. And the need for hospitalization and deaths is going to be 0. So that's the data that we'd like to underline. So for vaccines have different effects on COVID-19. Most urgent at this time is really to prevent disease among high-risk groups. Turn COVID-19 into the common cold. Wala naman namamatay masyado sa sipon. So in that case, wala na tayo masyadong problema. Of course, we'd have to still do our minimum health standards because people can still be contagious, but at least people aren't going to start dropping dead. Not enough vaccine from one producer, and that is why we need to use all the scientifically proven vaccines as soon as possible to save lives. Aside from the fact that we want to use multiple vaccines so that the virus doesn't figure out a way to become resistant to them. So Pfizer, Moderna, Astra, Sinovac, plus the other vaccines that are proven to be safe and effective will decrease the danger from COVID-19. So if you're a frontliner, which most of the people in this webinar are, as long as something is properly approved by our vaccine experts panel, the FDA, and that's the only one that's available, I strongly recommend that you take it because it will protect you from severe disease. If you're not high risk naman, you can wait for the better vaccines, or maybe baka later on there's going to be a transmission blocking or one that will last longer. Pero right now, because of COVID, because of us, frontliners and also the elderly, clear and present danger. So you really want to decrease your risk of severe and therefore risk of dying. So shifting gears to the forecast. If we stick to what we're doing now, minimum health standards, the case numbers seem to remain manageable. Of course, external threats like variants can always make us more cautious, and that's why we've actually done the travel restrictions. Economy can remain open while the vaccines are being rolled out, as long as we stick to these prevention measures. Small surges can be proactively addressed with contact tracing, if necessary, localized lockdowns. We cannot afford any more of those big lockdowns. Magugutom tayo lahat. There's much improved case management now. I did lose a patient this morning to COVID, but it was the first one in about 3 months who died on my watch, and I do see COVID patients regularly. And the survival rates are good even for severe cases nowadays because we have the tools to take care of them. So how do we end the pandemic? So this will end when herd immunity is achieved, either way, natural or vaccine, or when the infection burns itself out. This happened to SARS and to MERS, but obviously SARS-CoV is not going to burn out. So the herd immunity, natural herd immunity, will need millions of deaths if not properly, if not controlled properly. And of course, with these variants coming out, there's no guarantee there will be herd. Kasi pag may lumabas yung variant, tapos maybe you get 70% of people who are immune to the old variant, pwedeng umikot na naman ulit yung bagong variant na yun. So, natural herd immunity, itapo natin yan sa basurahan because it may generate a new variant to which you don't have herd immunity, and it's going to be a real problem. Paulit-ulit lang yan. So, no to natural herd immunity. The other way to accelerate herd immunity, if it exists, is with a vaccine. But we need vaccines that are transmission blocking. And we haven't proven that yet, but there is tantalizing data that some of the vaccines are at least partially transmission blocking. And so we have to keep studying that. And you want to decrease the deaths we will see, it will decrease as immunity increases, particularly in the high-risk populations. Because even though continued transmission, if we vaccinate all our vulnerable population, they may get sick, but they're not going to get severely ill. And so the deaths are really going to drop by a lot. The virus can also mutate to a less virulent form, just like with the other seasonal coronaviruses. We hope that this does happen, or have low level of transmission. This actually happened with one particular variant in Singapore, which was less virulent. Unfortunately, it was at survival disadvantage and it disappeared. But this can happen, and this is probably what happened to the common cold coronaviruses. So the time frame, if we did not have a vaccine, this would have taken 2 to 3 more years or longer. But with the good vaccines, with a fast rollout, maybe 1 more year less is hopeful. But at the rate we're going, the supply is really more than the demand. But we can do a good job of preventing deaths. We can go from 2%, 3% deaths to maybe 0.1% if we can vaccinate first all our vulnerable populations. And the goal is really to minimize deaths, protect the healthcare system in the meantime, and minimize variant emergence and loss of vaccine efficacy. So we are learning to take better care of patients, and we can keep cases low with proper use of PPE, adherence to minimum health standards. And I will guarantee you, all pandemics end. How fast we get there is up to us, and also how fast we can get our vaccines out and protect our vulnerable populations. Thank you very much.
Thank you, Dr. Salvana, for that very nice talk. Again, very informative, and I learned a lot from this talk. We have around 300 participants in the Zoom and around 50 in Facebook Live, and we have a couple or a bunch of questions in the Q&A box. But well, as a moderator, I have the privilege to throw the first question to you, sir.
Sure.
Do we have already a WHO definition or even CDC definition to say that the pandemic has ended?
Yeah, that's actually something they kind of vote on. They sit down and they look at the pandemic curves and they see what the transmission rates are. Is it down to a level that's not likely to sustain community transmission? And then they say, oops, okay, it's over. Parang declaration of ceasefire kahit nagbabarilan pa yung mga tao sa likod. So it's really something that's declared. Parang clinical diagnosis siya rather than an actual diagnosis. They may have metrics in terms of R0, estimated number of cases, but it's really more of like, okay, this looks like it's ended. We'll declare it. If you remember sa yung H1N1, parang ganon, they decided in one of their meetings na, okay, tapos na to. And because it's gone down below a certain level. It's like spikes or waves, diba? There's no formal definition. It's really more of an expert-driven definition. And HIV as a pandemic hasn't ended, actually.
Correct. I agree, sir. Let me go to the question, sir. First question is on the management. You did mention this in one of your slides. How about hemoperfusion? What's your experience on hemoperfusion? In QualiMed, we do hemoperfusion, and one nephrologist actually told us that we had more hemoperfusion cases than in the Philippine General Hospital. So, what's your experience, sir, on hemoperf?
Yeah, actually, you guys should write that up. Alam natin kung ano yung experience niyo. Kasi just looking at the literature and what the US NIH recommends, it doesn't seem like there's much evidence to for or against. And their recommendation is really to just do this in a clinical trial setting. So I don't think there's enough data to support it. But if you guys have a lot of data and it looks favorable, please publish it so that we have a basis for making that recommendation.
Yes, sir. One of our residents, or two of our residents, are actually working on it. Let me go to the vaccine questions, and then this is a hot topic. First question. Ito, ano pa lang, sir, wala pa yatang 5 minutes yung talk mo, meron nang nag-post ng question na to. Doesn't want a politically correct answer, but based on your study between an mRNA vaccine, a protein vector vaccine, and an attenuated vaccine, which one would you aspire to give to your loved ones, parents, and dear wife?
Yeah, I have
available.
Right.
Everything
Yeah. Yeah, I don't think there's any data that one is better than the other, particularly for severe. The other thing is that we have to look at the populations of the clinical trials as well. Right now, there are no vaccines proven for kids. The clinical trials for children are only starting. We know that mRNA vaccines are new, so there is some more caution, especially for elderly population with these reports of allergies and Bell's palsy. But causation is very difficult to link. For inactivated vaccines, we're used to those kinds of vaccines, but it's also the reason why we have maybe lower level of take kasi ang dami talagang spike protein yung ginagawa ng mRNA vaccine. But at the same time, because it's inactivated and whole and it's not just a spike protein, you might actually get better T-cell responses and you might actually have longer memory for these. So I think that it's too early to say which vaccine is best kasi hindi lang naman efficacy ang tinitingnan dyan eh. It's how long it will last, how antigenic is it, will it work against the new variants, and also the overall safety data. We have 2 months of safety data, no long-term na 1 year. And that is why it's very important to understand this is emergency use targeted towards the most at risk. Because for lower risk people, it might actually be better, lalo na sabihin natin essential workers who are up and about. It might actually not be a bad idea to hold out for something that we know is transmission blocking, because that will prevent outbreaks in the setting. So it's not that it's politically correct or not. It's I genuinely don't know. And that there is incomplete data, and trying to compare things sometimes is apples to oranges, and is difficult. What I do know is that if the vaccine efficacy panel approves, especially for severe, for preventing severe infection as a high-risk person, whether you're elderly or a frontliner, I would recommend you take it because that will protect you immediately.
All right, thank you, sir. In the clinical trials for Mrna, what percentage of the population developed severe allergic reactions, and was there a mortality because of the Mrna vaccine?
Yeah, that's actually published in New England Journal of Medicine. I'm not privy to, I can't remember offhand if there were any deaths in either way. I think there were, but they were not vaccine related. Otherwise, that's always all over the news if there's a vaccine related death. So in general naman kasi, if we look at the safety data, it's really, you expect more mild adverse reactions, especially for a highly antigenic vaccine, and maybe some more allergy type symptoms. So as long as these are not severe adverse events, you can do your risk benefit analysis and decide whether it's good or not. And in these cases, especially for emergency use, we have target populations naman that are at high risk.
Okay, sir. It's already 12 o'clock, sir, but I hope you don't
Go ahead.
mind.
No problem.
Like advantage of your presence here.
No
we have
problem.
a lot of questions.
Yeah.
How about, sir, according to the phase 3 clinical trial of Pfizer, vaccination did not prevent transmission, only prevented the development of severe disease. How is that? So,
Right. Yeah, they're starting to actually do swabs now, prospectively, and I think there was a subgroup where they were doing swabs, and it was about 25% in terms of asymptomatic. It was a small number, but I think they're going to continue that forward. Again, the issue, the reason that they focused on clinical outcomes is because that's the fastest trial to do, and because somebody gets sick i-test mo siya, di ba? So that's kind of like your action point. And the whole point naman of the vaccine, at least for emergency use, is really to prevent deaths. And so what you really want to look at are the prevention of the severe deaths. And just using their minimum of 50% clinical efficacy, the calculation there is that some percentage of that 50% will most likely be severe anyway. So that's why hindi nila linagay 70, 80, 90% clinical efficacy. They thought that 50% at most, if you can get half of the severes, that's good enough because it will prevent death. In this case nga, even though mababa yung events of severe, it was 0 versus 30 sa Moderna, 0 versus 10 sa Astra, 0 versus 7 sa Sinovac. The confidence intervals get bigger, but it's still all statistically significant. These vaccines all prevent severe disease. Did Mark freeze? Okay, I think we froze or something.
sorry, I think I'm losing Dr. Salvana.
Yeah.
Okay,
Okay, go ahead.
I think I'm back.
All right.
Can you hear me, sir?
Yeah, I can hear you. Are you there? Hello? Hello? Did
Nawawala si Mark.
nawawala si Mark?
Ikaw na lang mag-moderate, Gina.
Let me see the questions.
While naka-freeze si Mark. Again, just a question. Di ba there's a trial where the subjects are actually infected directly? There was a proposal na directly infect na to know the ano.
There was a proposal, but I don't think it passed through po. Kasi, hi Mark, you're back. Well, we were talking about trials that were where subjects were directly infected, but hindi yata natuloy yun.
Edsel, there's a question. Can we give mRNA vaccine to persons with autoimmune disorder?
Yeah, I think some of the rheumatologists and immunologists had addressed that, and I think the important thing lang naman talaga is that you consult your doctor and weigh the risk if you have any allergies or any other potential for ending up with flares. That was really the only comment there. It wasn't an absolute contraindication it wasn't an absolute contraindication to giving the vaccine if you had an autoimmune disease. Just make sure you talk to your rheumatologist.
Okay, sir. Sorry, I got disconnected, I think. Let's go back to the vaccine, sir. How about UK variant or whatever variant, mutant variant there is the vaccines that we have right now or being rolled out effective against this variant?
All right. So we have some preliminary data where they took the serum of people who got the Pfizer vaccine and used them to neutralize the UK variant, and for the most part, it worked. Naman, there were some there were some decreases in vaccine efficacy for some of the antibodies that are generated, but the other antibodies took up the slack. So for now, it looks like it's going to be okay. But we can't afford to keep generating these variants kasi baka magka-jackpot na bumaba talaga yung vaccine efficacy. And having said that, the vaccine efficacy is not going to go from 95% to 0%. You'll see 95, 90, 85, in which case you still have time to tweak it. mRNA vaccine, baguhin mo yung sequence or dagdagan mo ng sequence, just the way we do with like PCV13, we add strains. So I think long-term, wala namang problema yan. We can adjust the vaccines.
How about, sir, if the second dose was missed? What are you going to do?
Right. I mean, this has been an issue, and here's the interesting thing: in the Brazil Sinovac trial, there was a subset of people who missed the second week dose, and they got them on the third week. Actually, tumaas yung efficacy by 20% because maybe 2 weeks is too early. Is the thing. But in general, kasi the way that these vaccine trials are set up, you take your best guess on the second dose. But the principles of vaccination in general is it's better to give a vaccine late than too early. And so I think it applies in this case also because it's going to be like a booster. Siguro as long as hindi naman isang taon na delayed, I think it's okay.
Sayang naman yung priming ng first dose.
Right.
But yeah, agreed. Do not give the subsequent doses earlier than what's scheduled.
Correct.
Not related to your talk really, but can you share your slides to us, even in PDF files, if that's okay?
Yeah, okay, that's fine.
All right. How much of the total population, sir, do we target for the COVID-19 vaccination to prevent transmission?
Right now, because we don't have any transmission blocking vaccines, I think it's moot to think about herd immunity at this point. We really want to vaccinate as many of the high-risk population as we can, and then like what Israel is doing, they're trying to vaccinate everybody, even at this point. But yung herd immunity kasi is really not guaranteed unless you have a transmission blocking vaccine. And so it depends on what we can afford. Should we wait for a better vaccine that's transmission blocking? We're going to have to wait for the kids' trials anyway. And so, but I think that we have to plan for it. That's why the plan is not 6 months, it's 1 year, 2 years, 3 years, because as things change, we adjust. Unlike in Israel, their goal is really to vaccinate every single person above 16 years old. And that's good because then we can see what happens to them.
Sir, regarding the mass vaccination, does this actually, can we achieve herd immunity if we do mass vaccination, or herd immunity is still impossible even though we do the mass vaccination?
Yeah, it's really dependent on whether there is a transmission blocking vaccine, number one. And number two, that it lasts long enough. Kasi if after 1 year, hindi na siya gumagana, the herd immunity will be gone as well. Maghahabol ka. It's like you're chasing your tail. Kasi magbo-booster ka pa eh.
This was, I think, asked yesterday in the talk of Carl Henson. But considering, sir, na meron talagang availability of the supply. Supply is not an issue. And the first vaccine that came out is Sinovac. And I got the two doses of the Sinovac vaccine. And then come later the year, Moderna or Pfizer came in. Can I receive 2 more doses of the RNA, mRNA vaccines if I got already the live attenuated one?
Yeah, the answer to that is no. No one knows. There is no data. Yeah, I mean, maybe somebody can be a guinea pig if he wants to do a study. No. I mean, we mix vaccines all the time. Like, for instance, a Hep B, kung hindi mag-take yung isa, di ba, we use a different brand and stuff like that. But we don't know if that has any kind of effect on neutralizing antibodies or The other thing is that because of heterologous prime boost, sometimes using 2 different kinds of vaccines, like what Gamaleya is going to do, might actually generate longer-term memory T-cell responses. So I think those are open science questions. But as for whether you could do it or not, you got me. I don't think anybody has the answer to that.
Good. There's one thing that I learned from the late Dr. Salvation Gatchalian. There's no such thing as vaccine overdose. Next question, sir, is how do we address those that raise ethical issues related to the vaccines or vaccine development? For example, will refuse the vaccine because it made use of aborted fetuses or experimentation, etc.
Yeah, I think Pope Francis. Yeah. Nagsalita na si Pope Francis dyan. He said that all the COVID vaccines are ethically acceptable at this time. So, basahin na lang nila yung press release ng Vatican.
What is the age group, sir, to be vaccinated? So are we going to be strict with the Pfizer age group and the Moderna age group? They have different age in their subject. So if the Pfizer vaccine will be made available, so a younger population will be may receive the vaccine, like 16 years old.
Yeah, well, there's two things dyan eh. Kasi iba yung manufacturer's recommendations and what eventually will be adopted by the country.
Mhm.
So, Pfizer is 16 years old and above. But of course, we're going to target the elderly people muna. If there aren't studies of people above 60 years old, that doesn't mean you can't use them. Just that maybe you have a little bit more caution, but you know that those people are important that we vaccinate them. So it's not even off-label necessarily kasi nakalagay naman greater than 16 years old. I think that what's important is we understand this is an emergency use, so there's still a lot of unknowns in terms of long-term safety. So we have to really balance it out. Ano ba yung risk na magkakasakit ng isang tao versus the benefit of, yung risk, the benefit that you will get from protecting against severe disease versus maybe the residual risk of not having complete data. And I think that each of that is an individual decision. We identify the high-risk groups, and then at the level of the individual, you still have to decide. Ang EUA is never compulsory. It's always, you really need to get consent because we need to understand that, there's still uncertainties. Technically, the phase 3 is not done, at least yung full safety follow-up. And so you are accepting a certain level of risk for a certain level of benefit. And that's an individual calculation.
All right, thank you, sir. The duration of the immunogenicity, sir. I know it's too early to tell for SARS-CoV-2 vaccine, but looking at the data from the SARS-CoV-1 vaccine, it did not really produce a lifetime immunity. So do we see the same thing in SARS-CoV-2?
Yeah, I think the current vaccines and even natural infection, they're pretty sure that durable immunity does occur for up to about 8 months. Beyond that, it's anybody's guess. It also the issue of the variants is up there, and just how cross protection will work. And again, that might also be vaccine specific. Because if you use a whole vaccine versus a subunit vaccine, the whole vaccine may actually be more resistant to viral mutations because it can generate epitopes at different sites for the virus versus if it's all just spike protein. But the mutate ng todo yung spike protein, you might lose protection.
All right, sir. Well, in the interest of time, sir, I'll just entertain last two questions. This is one from FB Live. Can you comment on the new guideline that allows 10-year-old and above to go out?
Yeah, you mean in GCQ areas? In MGCQ area. You're gonna have to ask the IATF why they want that. Well, my understanding is it's they're trying to open the economy up, and so maybe that's the best answer to that. And I'm glad they're not doing it in Metro Manila just yet kasi GCQ tayo. Maybe they're just trying to pilot it and they can go from there. It's their call because I think that we're from risk aversion to risk management at this point because bagsak talaga yung economy natin eh. So maybe that's part of the reason. But it really does have to be done carefully, watch. Kung may spike, then you can walk it back.
You actually don't see a lot of children roaming around, even in malls, but you see a lot of senior citizens. Yeah. My last question is actually from Dr. Cynthia Talia. Ma'am, thank you for being with us. Can patients who had COVID infection previously be vaccinated still? Do we need to antibodies or titer before vaccination?
Yeah, no, we don't need to check it. You absolutely can get the vaccine because some people with mild disease don't develop much of an antibody response. So mas predictable talaga ang antibody response ng vaccine. The guidelines that were done in interim guidelines, and these change, is wait about 90 days from the time of infection. the diagnosis of the infection before you give the vaccine. WHO actually mas extreme pa nga 6 months ang gusto nila that you wait 6 months. But the CDC guidance says that, okay, 90 days, it sounds about right. But you can give it even earlier on a case-to-case basis. Like somebody who's immunocompromised and doesn't really generate much antibodies and needs some protection or frontliner or for whatever reason if they don't generate. But there's the other problem is we don't know what level of antibody is protective and whether it's neutralizing antibody or not. So there's actually no point in checking antibody. Because if it's positive, is it protective? Who knows? Even if you have a way to check neutralizing antibody, what level? Diba? And if it goes below this level, do I inject you again? So there is no data to support those kinds of. I mean, it would be nice to study, but at this point, I think that those are all very practical guidelines, especially as we're rolling out and making sure that everyone gets a chance at getting vaccinated.
All right. Thank you, sir. We still have a lot of questions in the chat box, but we'll try to forward them to Dr. Salvana, and hopefully Dr. Salvana could address this question. We'll post it in the QualiMed Facebook. Again, thank you so much for your time.
Thank you very much. Yeah.
We really do enjoyed your talk here in QualiMed, and thank you for accepting this invitation. With that, I'd like to present this certificate of appreciation to you, sir. This e-certificate, which reads, to QualiMed Health Network, so I would like to present this certificate of appreciation to Dr. Edsel Maurice Salvana for his expertise and valuable role as a speaker during the webinar entitled How the COVID-19 Pandemic Will End, given this 22nd day of January via Zoom virtual event, signed by Dr. Maria Gina C. Nazaret, our PSQ and consultant, and our CEO and President, Dr. Edwin M. Mercado. Again, thank you, sir, for gracing us today.
Thank you. Thank you very much.
And also, I'd like to, on behalf of the QualiMed Health Network, like to present this certificate of appreciation to Natrofarm. Hi, guys. Nice to see you again. For the company's valuable role as host during the webinar entitled How the COVID-19 Pandemic Will Likely End. Again, given this 22nd day of January via Zoom virtual event signed by Dr. Nazaret and Dr. Mercado. And with that, I'd like to thank everyone for joining us. Again, until we get the vaccine, still stay safe, and God bless us all.
Thank you, everybody. Nice lecture, Edsel. Thank you.
Thank you, Pa. Thanks, everyone.
Thank you. Thank you, Edsel.
Thank you, ma'am. Bye, Mark.
Thank you, Mark.